Any type of cancer and treatment is a journey no one wants to be on. For women, the added risk and fear of breast cancer adds another layer. What if there was something to help you detect breast cancer earlier if you are someone at high risk of being diagnosed with breast cancer?
The MRI just picks it up on different people in different ways, and I have personally seen these women who are diagnosed early, who can get their treatment started early and survive breast cancer.
That's Michele Settelmyer, APN for the Risk Assessment Program at the OSF Center for Breast Health, and I'm Shelley Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. According to the American Cancer Society, breast cancer is the most common cancer for women in the United States, except for skin cancers. It accounts for 30%, or about 1 in 3, of all female cancers each year. Breast cancer mainly occurs in middle-aged women and older women, with the median age 62. A small number of women are diagnosed younger than 45. Early diagnosis is important. Cancer IQ is one tool used by OSF HealthCare to help identify patients who are at high risk of getting cancer based on their personal or family histories. As part of that assessment, some high-risk patients are identified as eligible for getting breast MRIs in addition to their annual mammograms. Joining us to discuss the Risk Assessment Program for Breast Health MRI follow-up pilot are Michele Settelmyer, who is an APN for the Risk Assessment Program at the OSF Center for Breast Health, and Roopa Fougler, who is the Vice President, Digital Innovation Development. So, Michele, after I say welcome to both of you, I'm going to start with you. Who is considered at high risk for developing breast cancer, and what is the Risk Assessment Program?
Hi, so the Risk Assessment Program is out at the Breast Center and anywhere where women can get a mammogram at OSF at our 4 locations. And when women come in to do their mammogram, they are given a short survey to take, which asks very specific questions on personal and family history. And if she is determined to be at high risk, then she's offered a chance to come in to have a meeting with me, and our program coordinator will send them a longer survey, which asks a lot of more in detail questions on family history, specifically cancer history, ages of diagnosis. And if she is determined that she does want to come in and have a meeting with me, we go through her family history, her personal history, and determine if she actually does qualify for genetic testing, if she wants to do the genetic testing. But if not, that's fine too. But she may qualify for adding an MRI to her screening. So we discuss that. And when women do that, they have the breast MRI typically about 6 months after the mammogram. And so I would order that, and then we do a 3-month follow-up to come into the breast center, and we do a hands-on clinical breast exam, a very in-depth exam, and then review her imaging and order imaging for the following year also.
Is it mainly a family history that kind of flags a lot of people to come into your world?
Most of them are based on family history, but a lot of women without family history still can get breast cancer, still can be high risk for breast cancer. It has a lot to do with reproductive history, breast density can play into that as well.
Okay, Roopa, I'm going to turn to you because you live over in that innovation space that is always working to develop different solves for something. So MRI management is a big part of this risk assessment tool. You come in. So walk me through how the MRI management works. And it's very precise, isn't it, for looking at managing the patients who are identified as high risk?
Yeah, that's right. So once the patient has been identified as a high risk based on cancer IQ as well as the work that Michele and her team do, there's an order that gets placed in the system. So what happened in the past was some of these patients have already had their mammogram done because that's where the high-risk assessment tool, the survey tool happens. And because there are insurance constraints that you need to wait for 6 months, and also you need to have the MRI done when you're not in your menstrual cycle. So there are a lot of criteria. And in the past, our cancer navigators would have to manually go through charts, look up and follow up with these patients. You're talking about 6 months out since the survey was done. And, cancer, as you said, especially breast cancer, is just increasing in prevalence, more so as compared to skin cancer. So, it was important for us to look at it from an innovation standpoint, how we can help our APNs in the cancer center operate at the top of their license. We don't want them, looking at charts and really focus on patient care, right? So what we did was, so at the innovation center, we have our teams that we collaborated along with them, with the process improvement team, with my team, as well as with the data team and with the navigators. And we kind of broke it down into how we can solve the problem. And one of the things that we had built through the COVID, and we learned a lot, and how we should be building digital solutions, we understood the importance of being able to orchestrate solutions to the data that we've obtained, right? Through process mapping, as well as taking the data that we already had and surfacing up through tools for the clinicians so that they can take the next step. So as we were kind of working through and trying to problem solve this, we thought this was a really good use case of what we had done through COVID to also apply in the cancer center and help our navigators. So yes, it was a very complex but problem if you apply it from a human standpoint, having to look up. But because we had the data infrastructure, the digital infrastructure, we are able to automate this and identify through the high-risk patients, know when their 6 months is up, reach 30 days before their 6 months is up, because you don't want to reach too sooner, right? And encourage them to schedule if they haven't scheduled an appointment, and also have a follow-up. And all of this is through our orchestration platform that digitally connects to patients. So we also know how the patient likes to be connected. If they prefer texting, we outreach automatically through text. If they prefer an email, it goes through email. If they prefer a phone conversation, then it goes into a work queue for the navigators to call them and connect with them. So we've been able to really streamline this. And of course, it's just been a couple of months. It's a pilot. And we hope to scale this up more and do more of this for other types of navigation as well in the cancer center.
So Michele, I'll come back to you. Just listening to Roopa describe this, it sounds laborious. It had to be, in the clinical end of it, challenging. Tell me about those challenges of just keeping track of all that stuff.
Right. We have a lot of patients that we're ordering MRIs for, and we try to do it about 6 months after the mammogram. So the schedulers were calling patients, and we like women to be mid-cycle if they're still cycling. And just getting all of that timing down is difficult. So if somebody wasn't able to make it that month, then they were put out another month, and just trying to keep track of all of that for all the patients we had was very difficult.
At the end of the day, this is about communication, isn't it? It is very clearly communicating to women, to the group that's identified. How is this different communication than, say, I'm on a list to get a reminder that, hey, you're due for your mammogram because of X, Y, and Z? How is this different than that?
So with the patients notified, and the schedulers do follow up with them for that phone call. And then also, if we didn't get them in afterwards, we're still continuing to follow up with that and asking them to call, or if they aren't able to schedule, why.
So I guess the difference is really understanding the preferences as it's recorded in our chart, right, in the patient's chart. also kind of nudging them, if sending them a first text message, and if we don't see a response. So we have like a feedback loop where we are able to understand that the patient respond or not respond, did they schedule or not schedule, because we have all of the data, and kind of nudging them along the way. And then the last would be someone calling them up and helping them make that appointment, or encouraging them to make the appointment. So we've been able to leverage data and digital solutions to really fine-tune where we needed to use our mission partners' time to really help up patients and nudge them along the way to get that important MRI in.
As with any pilot, the goal is to learn, tweak, improve, make adjustments. What have you learned over the course of this pilot? Like you said, it's only been in place for several months, but what have you learned over the course of this pilot?
I guess I could speak from a data standpoint. What was surprising to me is, as we were looking at, this is a small subset of our population, right? We were expecting more patients, because it is middle-aged and above. We were expecting more patients to prefer phone call. We were actually seeing from the data more patients actually preferring texting and emailing, and our navigators were like, hey, I'm not seeing anybody in my work queue that I need to call. That's because most of the patients preferred, in their preference, right, connect to me digitally, which was interesting to me, because I did not expect that. Even though I'm working on the data and I look at the analytics side, it was eye-opening.
What about from the clinical side? What have you learned?
Oh, the nurses love it, because they were helping me call the patients. It was a team effort that we had to do, and we don't have to do all of this work anymore. Because when you are calling patients, you phone tag and you call, they call you back, you call. So it's a huge time saver for us.
So let's talk from the clinical diagnostic side of things. What are the benefits to this MRI follow-up ultimately for women who might be facing the scary prospect of breast cancer?
So ultimately, the goal with the whole program is early detection. And an MRI is a tool that we can use that gives us a very good screening of the breast, different than the mammogram. It is different. It's going to see more. It's going to pick up an earlier breast cancer, and it's going to see through any breast densities.
Anything from your perspective on why this is so important? I can see this having other,
Yes.
processes for other similar
Yes.
types of communication, correct?
Yeah, so the learnings, right? Because in innovation, as we pilot, it's not just the success of the pilot. A lot of times it might not be successful. It's the learnings and how we take the learnings and apply for a better solution, right? So the learnings, absolutely, as you stated, this is something that we could expand to other type of cancer, and where navigation, is needed. And how do you, bring in the best of both worlds, right? Digital as well as people. At the end, it's not just digital. You want a person at the end that the patient can always connect to, but how do we maximize the benefits that the navigators bring? Because it's just, unfortunately, as we have a destination cancer center, right? It's just a lot happening, and we definitely want to protect their time and give them the time that they need for the patient care. So I think that has been a big learning, that we can expand what we've done here. The next is just how do you connect all of these different systems together so that we can make it easier for them and streamline, right? So that has also been definitely a learning from a digital standpoint, right? A lot of times from a technology, you think you build an awesome technology, but when you actually go and implement it, right, in real life, it's completely different, especially in patient care side, where it's very complex and so many variations and things can happen. So we've learned a lot, and recognizing that you want to partner early on with the folks that are going to be working, and it's not like you just work in isolation, right? That's one thing we ensure in the innovation side, that the business teams or the places that we want to solve, they're also part of working with us as we build solution, has been another important learning for us.
I love having conversations with Roopa. You think she gets excited about her work? I see the passion just talking with you. Is that one of the things that just makes this work so important, or you can see the possibilities?
Absolutely. I mean, for me, I always tell people that OSF and joining OSF more than 15 years back was a calling, and this is sense of belonging here, and being able to actually be present and see the problems that are challenges that our clinicians are going through, our care teams and the operations team is and wanting to help them, right? Especially we've heard so many issues through COVID, burnout, and all of that. I mean, that's a big driver for me, that I definitely want to help the people that are helping our patients and serving our community. And how, not just me, the whole innovation center, how can we be there and help there? And the fact that we are located close to the hospital is another big benefit. If we wanted to do a Gamba walk or things like that, we're able to go visit and see that. So I think it's just the mission of the sisters and the whole, I guess, the leadership team and the environment in OSF is a big driver, yeah.
Michele, why is this work of this breast cancer risk assessment and the MRI follow-up pilot, why is it so important from your perspective?
Because I have seen early detection on breast cancers on women since we've started this program, on many different women, and people who do not have a family history of breast cancer, and people who do also, but the ones that are very surprised that they are diagnosed with breast cancer. And they're so grateful that we offer this type of program for this early detection, because we don't know when we would have seen that cancer on a mammogram. And mammograms are great. We detect a lot that way, but the MRI just picks it up on different people in different ways. And I have personally seen these women who are diagnosed early, who can get their treatment started early, and survive breast cancer.
And
yeah, I was just going to add something. So I also wanted to say that I'm a cancer survivor, and almost close to a decade back, I had the Cancer Navigator. I was in the Cancer Navigator program, and I personally got to see as a patient how much work effort these navigators had. And anytime I had any question, I could call them, anything. And the phone tagging that Michele talked about was something that I was clearly seeing, right? I would call and they're busy and they would call me back, and and I was not available going through treatments and all of that. And that was also another reason to your question, why I'm, especially on the cancer navigation side, being there as a patient on the other side, anytime I could reach out to them. Sometimes I did even late during the days or in the evening, and they would always respond. So I felt a calling that I need to figure a way to make their lives easier, and I'm hoping, of course, if we are not there, I'm hoping that we could support them in any way from a digital navigation standpoint.
Once again, the fabulous work coming out of innovation, pairing on the clinical side, all to the benefit of our patients. Michele Settelmyer, Roopa Fougler, thank you for sharing this story, with many more to come. And thank you for joining us as well. And a reminder, you can check out all of our podcasts. Go online, osfhealthcare.org/accelerated.